Hey, buddy, good job. Thanks for staying on time. Dialed in. I love it. I think we have. What's you? You want to run the show here? Do it. So we get the word. How are you doing? Do you think you hit this button?
Hello. Hi, everybody. We're going to get started in just a minute or so because we ran over a little bit with the last session, which is always a good thing. I'll introduce myself. I'm Dina Podolsky. I'm part of the Columbia Hernia Center coming out of New York.
Yeah, good morning, everyone. John Fisher, plastic surgeon from Penn. Really excited to co-moderate this panel with Dina, redefining key measures of success in hernia repair. We got an awesome lineup of speakers, so we're going to kick this off.
Yeah, we just really wanted to, with this panel, talk about something a little bit outside the box. As ab wall kind of grows in scope and size, we really have to figure out what our measures of success are in the field. So we'll start off with Desmond Hune from University of Michigan in place of Dana, and they'll be talking about current trends in hernia surgery research, level 1 evidence, NIH funding, and trends in publication. Thanks, Desmond.
Thank you. Hi, good morning, everyone. I am Des Hune. I am the current MIS fellow at the University of Michigan. Just wanted to thank the Society for the privilege of presenting today. Today we'll be talking about our kind of the state of affairs in hernia research, a look at level 1 evidence, NIH funding, and trends in publication, which is an appropriately long title for kind of the breadth of this topic. I am giving this talk on behalf of my mentor, Dr. Dana Tellem, who's really the visionary and architect behind all of this work we'll be talking about today. I don't have any relevant disclosures to this talk, and here are our funding sources. So I did want to start out with a disclaimer. NIH funding, trends in publication, evidence, all of these are huge topics and they can really be applicable to a wide set of areas within hernia research, from basic science to innovations research. But the effort to keep this talk at around 10 minutes, I'm going to lean into our strengths at U of M and kind of focus on specifically health services research and trends in that space, and hopefully kind of paint this picture in that space specifically. So kind of the overarching theme that we have been focusing on, especially in our NIH-funded research, and kind of what we see as the next generation of health sciences or health services research, is specifically on implementation. So that is closing gaps between the evidence that we've generated and what actually happens in the clinic and in the operating room. So the focus of our funded research has really been on the implementation science, which we'll talk a little bit about in a little bit, to affect change in clinical practice. Just taking a quick step back, why focus on this? Why work on implementation? And is this a kind of worthwhile place to invest our time? And we think it is. You know, when we look at our outcomes in hernia on a population scale, despite a really robust academic community and the generation of a lot of great evidence, we've seen some changes, but maybe not quite the improvements in outcomes that we'd hope to see, especially with all of this new evidence and data on a larger scale. And so, you know, somewhere the rubber is not meeting the road. For this talk, we're going to focus on kind of 3 trends that we see within the research and publication space that are kind of barriers, places for improvement when it comes to getting the evidence into the clinic. So the first one we're going to talk about is kind of at the level of where evidence is generated. So, you know, historically, we have a lot of great studies that were the best at the time, but a lot of them kind of failed to capture data on intersectional populations. And in overlooking that, we may have lost insight into kind of the highest quality data by not looking at all patients, all populations. If you look at some of the older big inguinal hernia studies, an example of this is kind of a oversight when it comes to looking at the disease process in females. And, you know, looking forward into building the highest quality evidence, all publicly funded projects, research trials will need to include these historically marginalized groups to try to address this problem in terms of quality evidence generation. So this kind of oversight is an example of one challenge to generating good evidence, which is lack of nuance in the data. There are a couple other issues that are kind of key to hernia that we're working on improving when we're talking about creating good data. One is a focus on long-term outcomes, and obviously those are particularly key to this disease process, but come with all the limitations of following up with patients after surgery. And then the other is this trend historically to kind of conflate quality of life with 30-day death and destruction outcomes. And I think we'll see, and we'll talk about in kind of the successive talks, how quality of life maybe isn't best captured by these morbidities that we've historically looked at. So what tools can we use to get around these barriers? Kind of where we've started and where kind of a good place to intervene is using high quality registries that are kind of sensitive, kind of attuned to these problems from the past. Examples of these are the ACHQC, the EHS Open Abdomen Registry, and in Michigan, we have our own population level hernia registry, which is the Michigan Surgical Quality Collaborative's core optimization hernia registry. And this is a registry we've been working on that is a statewide registry, collects hernias from the entire state and follows patients for about a year after their operation. All the data is abstracted via HIPAA-compliant phone and text message to collect patient-reported outcome metrics, and able to try to collect some sensitive or sophisticated data kind of on a population scale. I don't want to steal the thunder from our later speakers who are going to be talking about these patient-reported outcomes measures, but in brief, the core collects the PROMIS 3A pain intensity score, the ventral hernia recurrence inventory, and the Hercules score. And to date, we have over 2,000 responses. Looking at the entire population, actually, of the state, this is a representative sample of all the hernia surgery being done in Michigan. And so we're hoping to gain a lot of information from this data. The second trend I want to talk about, we've kind of talked about generating high quality evidence, is what do we do once we have the evidence? And kind of from what we've seen, to put it bluntly, it's not enough to just generate high quality evidence. We need to focus on kind of the implementation of the evidence in clinical practice. And this kind of goes back to the implementation science, which has been a kind of the main thrust of our NIH-funded support. So we use kind of techniques in implementation science, and kind of this can be broadly characterized into three classes of studies, or hybrid studies, classified from 1 through 3. We kind of use a multidisciplinary team to carry out these studies, and we look at kind of the evidence and the way in which they're implemented to see how we can improve either on the understanding the effectiveness of the evidence itself or the successfulness of the implementation. So we decide which kind of study to use based on the quality of the evidence. So starting with hybrid type 3 there on the right, this is for a study where you think that quality of evidence is pretty uncontroversial, it's well accepted, and the focus here is to see kind of test different strategies for implementation and see how they perform for something that we know works. For hybrid study type 2, this is for something where we are starting to want to be able to start measuring the degree of implementation, something where we think that it works, but we're not exactly sure how to get it into practice. This would be something like smoking cessation. We have a good body of data for it, but we need to measure how it's implemented and see how it's delivered in the clinic, see what interventions are successful. And then finally, hybrid type 1 is for testing innovations to see if they're effective. So does this mesh work? But with a specific focus on kind of the context of implementation of that technology, and making sure to pay attention to any barriers to using that innovation going forward. So what's an example of some of this innovation science that we've been doing? The kind of representative case study that for our research is in preoperative optimization. I think it's no question that optimization of obesity, smoking, diabetes are foundational to a successful hernia repair. And while this isn't particularly controversial on the level of evidence, when we looked at our findings in the state collaborative, we actually found that 25% of persons who underwent elective repair had an active contraindication when it came to preoperative optimization. So again, there was some discrepancy between what we know we should do and what was actually happening. So how do we take a look at this? Well, we identified our practice gap, which is this difference in what we know we should do and what's actually happening. And then we wanted to kind of do a deep dive into this. So we looked at our QC data, we did some qualitative study, carried out a lot of interviews to try to evaluate the barriers to implementing these preoperative optimization throughout the state, and specifically what barriers there were and what strategies we could use to overcome them. And what we found were that there were 3 general types of barriers: financial, knowledge and research access, resource access, and barriers at the institutional level and in practice pattern. And then there on the right, you can see kind of strategies for mitigating these barriers, going from kind of least complex to most complex. So starting with pay for performance, which is kind of the most simple to roll out, and going all the way up to on-site facilitation, which is obviously a little more costly and more expensive. And so to study all of this and study how these interventions might best be used, we performed a SMART trial, which is a sequential multiple assessment randomization trial, to try to look at what interventions were best and most effective at rolling out preoperative optimization in the clinic. So, the idea here is we want to right-size our intervention. We want to be most cost-effective by just doing enough so that these the preoperative optimization is happening at the lowest cost. So, starting out, sites were enrolled in P4P. Depending on how they did, if they did successfully, they were continued on the pay for performance. If they didn't, they were either randomized to pay for performance continuation to make sure that there was no lag time effect going on, or they were randomized into a kind of more intense intervention to see if they would respond to that. And this is the kind of a type 3 study, going back to the classifications we talked about earlier, trying to put into practice, find the best way to put into practice what we already know to be true about preoperative optimization. And then finally, kind of after we work on generating the best evidence and figuring out how to implement that evidence, we want to focus kind of on how to communicate these findings. So 3 groups that we hope to communicate these findings to going forward. This is other clinicians. In general, we do a really good job of communicating within the surgery family through meetings and guidelines and recommendations, but some of this information isn't reaching other clinicians. So there should be some consideration for publishing out of the normal surgical journals. As well, we want to reach payers and funders, for a number of reasons. Hernia is underfunded compared to other groups, and I don't think that's because we lack motivation or smart people, but there is a kind of funding gap when it comes to public hernia funding. And one way that we can maybe expand on our success in this field is contextualizing our research in terms of approach. So reaching out to funders and payers in terms of AI in hernia, or policy or implementation innovations in hernia. And finally, we want to reach out to the patients. I'll just go through this quickly because I think I'm going over time, but in terms of communicating with our patients, we also want to focus on ways in which we can communicate communicate the science in a way that's easy for them to understand. And this is just one of our tools that we use, the Hero IQ calculator. This is actually just a prototype, so not quite ready for prime time if we could not tweet this out quite yet. But this is a risk stratification calculator. It's meant to be a kind of risk communication tool between surgeons and patients. What we worked with behavioral health scientists to kind of talk about how to communicate risk to patients, because there's this concept called numeracy, where it's very difficult for folks to kind of understand numbers kind of as is. And so by having a calculator like this, we can kind of represent patients' risk as they are, our goal after preoperative optimization, which is this green dot here, and then average risk in our population. And by doing that, we can kind of create a conversation that's accountable and transparent between surgeons and patients, and account for both of their levels of risk tolerance.
Desmond, I think you gotta.
Oh yeah, sorry. I'm sorry. And so, final slide. In conclusion, the kind of 3 things we like to focus on going forward in our future trends in research and publication: equity in creation of the data, making sure that we're matching the measurements and metrics to the procedure, and then generating data in the context of its implementation. Thank you for your time. This is our team, and thank you for listening.
All righty, just these sessions are pretty long as is, so just when that clock hits, wrap it up. Yeah, no problem. So next up is Philip George. He's one of my partners out of Columbia, and he'll be talking about what does it mean to be a hernia center. Thanks, Phil.
Keep it going, keep it going. Don't stop it, I'll do it through it. Well, thank you very much to AHS and the moderators here. I'm Philip George with Columbia Hernia Center, and I'll be talking about what it means to be a hernia center. Really fun topic. I have no disclosures, and no artificial intelligence was hurt in the making of this presentation. Very good at AI logos, though, as you can see here. But let's start with the basics. Let's do hernias by the numbers. So in the United States, there's roughly about 600,000 ventral hernia repairs done every year, about 1 million inguinal hernia repairs now. If we're looking at the world in its entirety, you're looking at numbers of up to 20 million or even more. And then you have other different types of surgeries, mesh removal, groin pain, et cetera. Residents usually at the end of training, and this is data from, it's a little bit older, 2019, usually finish with about 100 hernia cases. About a quarter of those are minimally invasive, And the most common ventral hernia repair exposure is an open repair with a preperitoneal mesh, or an intraperitoneal mesh rather, which is fairly low in my algorithm. And the other thing is about a fifth of residents have never even heard of a rectus rectus hernia repair by the time they graduate. Those numbers may change, but this is sort of where we're starting with, not very good. Some other problems with hernia care is that there's a lack of standardization of surgery. You know, we all have different algorithms for different types of procedures, even for the same type of hernia, and they're all right and they're all wrong at the same time. Along with that, there's an exponential increase in complexity and numbers of techniques, which is hard to teach in residency. It's also hard to teach in a specified fellowship, along with numerous devices, different types of robots, instruments, mesh. It can be pretty overwhelming even for me, and I do this for a living only. In the United States, there's no surgeon-run accrediting body to determine who's a hernia surgeon or what is a hernia center. Now, they're a little bit more advanced in Europe. You know, starting in 2021, you could be a fellow in abdominal wall surgery, but we still have a long way to go. But the reality is general surgery is fractured into multiple different subspecialties, and I think that shift is likely to continue. However, most hernias are not done by hernia surgeons. They're done by general surgeons, which is unlike a lot of the other subspecialties, such as cardiac, transplant, pediatric surgery. But why do we need a designation? So we've seen sort of something like this before, the sort of vicious cycle of hernia recurrence and repairs, where you have hernia repair, something goes wrong, there's a complication, you get a recurrence, reoperation, so forth until infinity. Typically, the hernia center comes into place at your recurrence. Now, when you think about high volume surgeons who do hernia surgery, I guess we could call those hernia surgeons, it's been shown that they have a lower rate of recurrence with primary and recurrent inguinals, primary and recurrent ventral hernias, as well as incisional hernias. So food for thought, you know, potentially we could consider putting the hernia center at the forefront of hernias. You know, just something to think about. I don't necessarily think this is the case, but something to think about. So centers of excellence is something that's been in healthcare for some time now, and it's very popular with other fields of medicine. But this is a really good definition that I found. So it's a program within a healthcare institution assembled to supply an exceptionally high concentration of expertise and resources in a particular area of medicine. And we've seen this for some time now. Look at the pancreatic cancer centers. You know, the mortality in these centers is inversely associated with volume. Now, it's actually been shown that the cost is a little bit more, but that's at the expense of increased survival. And that's usually due to some ancillary services and stuff like that. The good thing about these centers is they're likely to be at places where you have other centers of excellence, so you have unlimited resources, basically. Same thing with bariatric centers of excellence. Once you're a center of excellence, you have a shorter length of stay, lower morbidity, and lower total charges. You know, not directly patient outcome related, but still very important. Non-accredited centers, you know, nicely enough, after they become accredited, actually show better outcomes as well. Now, this is where insurance gets into the mix. So Medicare would only pay for bariatric surgery at one of these centers. But as the great Professor Robert Fitzgibbons once said, everyone can say he or she has the best technique or their practice is a hernia center of excellence. Most of the time, it's just calling yourself a center of excellence. And like the great Michael Scott, you could just declare bankruptcy and then it just happens, I guess. But it doesn't really mean anything. But what is a hernia center? So, I mean, this concept has been around for some time now. You know, Scholdice first opened their doors in the 1940s. But now today, if you just type in hernia center into Google, you'll get about 6 million hits. So I asked our best friend ChatGPT, what defines a hernia center? Sort of a cop-out here. But if you take all the fluff away, all the nonsense, it's actually pretty good. So it tells us that we need experienced surgeons doing customized treatment plans, incorporating research and innovation, coordinating care, outcome tracking. I mean, it all sounds pretty good. But who really decides? So at least in the United States, we have the Surgical Review Corporation. It's a nonprofit which designates centers of excellence in certain fields of surgery and medicine in general. You have country-specific hernia societies which designate centers of excellence, especially in Germany and Italy, which are sort of the poster childs for that. Or if you have a marketing team and some imagination, you too can be a hernia center. A little bit about the SRC. It's been around since 2003, and they, you know, tout very nice results from their accreditation status. So if you look here, you have decreased complications, decreased costs, improved efficacy, efficiency. You know, all sounds pretty good. And to be a master surgeon in hernia surgery, you have to have experience, at least 90 cases a year. 15% of those are complex. They say that ventral hernias are complex hernias. I don't necessarily agree with that. You have to have a facility, some CME, you have to have your own algorithm, a team, and participating in some sort of quality improvement initiative. You could use their database. And for the low price of $2,800, you can have yourself a hernia center. So why stop there? Because they're credentialing a lot of other things, hernia surgery, kidney stone management for some reason, minimally invasive surgery. Let's say you do 100 robotic inguinal hernias and 50 lap choles. Boom, there you go. You're credentialed in hernia surgery, minimally invasive surgery, and robotic surgery. If a couple of those patients have kidney stones, you can knock that off as well. And baby, you got a stew going. So let's look at the Italian model. So there are 3 levels to the Italian model for hernia surgery credentialing. First is the single surgeon, where you have to have enough volume. Your outcomes have to be good, as designated by what they think. The second level is your referral center, where you have to have 2 credentialed surgeons in a hospital with an ER and an ICU. A little bit more volume, some abdominal wall cases, and the ability to do complex cases as well. And that's where you should be affiliated with a plastic surgeon and a wound care center. The third level is where you have 3 surgeons, a little bit more complex stuff, but a minimum amount of complex inguinal and abdominal wall. And they require you to get a research fellow, yearly workshop, as publications too. The German model is not so different, also very good. You need to have a certain number of volume as well as good outcomes, and they do require you to be a part of their registry in the Hernia Society. The competence center is a higher level up where you have a little bit more requirements, along with a multidisciplinary care team and conferences. And then the last one, you have a requirement for complex cases, hiatal hernias, as well as association with a plastic surgeon, publications, as well as hosting seminars and guest visits. But how do we really quantify and qualify outcomes? So, since the end of time, we've looked at recurrences, complications, length of stay, acute and chronic pain, as well as cost. And based off the Italian and the German models, this is sort of the criteria we're looking for if you want to be credentialed as a hernia center. But it's good. It gives you some leeway with complex cases, some abdominal wall cases. And they do note that complex abdominal wall reconstruction has a higher threshold for that, which I think is good. But, as we know, these complex cases are, lead to complications. That's just what they do. But a lot of these risk factors and a lot of the newer techniques are a little bit harder to capture. So I guess the question is, should these be done at a hernia center? Let's look at the Access project from Europe. So this is a group of 18 EHS-backed experts looking at, what we need to do to designate hernia centers. So there is a need for a hernia center, and there is a need for different layers of specialization as well. So the consensus is that it should be accredited by a national or international hernia organization, which makes sense with reaccreditation every couple of years. You need to have a CT, MRI, ultrasound, ICU. If you're part of an academic medical center, that should be fairly easy. And then you have to have a morbidity mortality conference and participate in quality improvement. This is where it sort of gets a little bit nuanced, but I think it's also fair as well. You should try to follow published guidelines, must be able to treat all types of hernias using all accepted types of repair, so you don't need to do anything fancy, and should have reasonable outcomes based off of what they deem as a reasonable outcome. But I think the main value of a hernia center, we can really use for good, like Dr. Nowitzki was saying. This is a place where we should have excellent adjusted outcomes. It's a place where research and quality improvement should happen and should carry forth to like the rest of the world. This should be a training platform for residents and fellows, a place to trial products because of the volume that's present there. And it should be used as an educational resource for other surgeons in fellowship, observership, mentorship, so on. But most importantly, it should be an extension of these national and international societies, which can lead to physician-led credentialing as opposed to corporation, leading to accountability and potential collaboration between hernia centers as well. So I think that's the way forward with practice designation, hernia center designation. And like Dr. Nowitzki was saying, the AHS is on it, so that's great, nothing to worry about. But I think this is sort of the setup that we need based off of the European models, where a surgeon should sort of get certified. Whether or not that's board certification or not is to be determined, and two levels of hernia center, a local and a regional center, regional centers with more complex care. One day in the future, we'll have peristomal hernia centers. I can send all that stuff to, but to be determined as well. But I think we should be careful, like again, what Dr. Nowitzki was saying. I think we should balance surgeon autonomy with outcomes. The point is not to take away from general surgeons, but should elevate outcomes in general. And I think we should balance the narrow versus the broad specialization. Is the Schuldeis Clinic a hernia center, for instance? I think so. I think they have excellent outcomes for very specific surgery, and that's all they do. And most importantly, we have to ensure fairness and oversight. One of the most important things we should avoid is, this is the end of the SRC, as opposed to patient stuff. We really shouldn't be focusing on using hernia centers as a marketing advantage. We really have to be using it as patient outcome driven. So let's make a hernia center really quick. We'll get an LLC, a domain, a website hosting, $1,000 for a website, $20 for business cards. We'll get SRC in the mix for $3,000. you're left with a $4,200 tax write-off. Nice little logo here. But I will say that this is what we have. This is sort of what we're dealing with until we can figure out something better. It may not mean stuff to us, but it means something to patients, and it means something to non-surgeons and referrals. So it does mean something.
Bill,
Yeah.
just a gentle reminder about time. All right.
Hey, I got
Thank
another
you.
minute. Anyway, a little bit about us, but I think it's really important here. Columbia Hernia Center, there's 3 of us. We have 2 fellows and a residency. To cut to the chase here, I think one of the most important things that we really do at our practice, and this is directly from our patient handout that we give to patients here, we showcase the different subspecialties that we work with. We show off that, listen, these are not just folks in their field, these are folks who work with hernia patients specifically, which I think is really important. But I think in conclusion, hernia centers are loosely defined, and hopefully we can come up with a better definition in the coming years. I think we need both a specialist and a center designation, preferably society run, and I think necessarily society run. But the EHS is working on answers. But overall, hernia center is hernia surgeons doing good hernia surgery. So thank you very much.
I apologize for always being a bad cop at this meeting, but sure we all want to get to lunch. All right, next up is John Fisher. John is coming from the University of Pennsylvania, where he's a professor of plastic surgery, and he will be talking about looking beyond postoperative complications, the rise of patient-reported outcome measures in hernia surgery.
Thanks so much, Dina. Good morning, everyone. Really a pleasure to be here. Congratulations to Archana and Yuri for a terrific meeting. I'm going to speak about patient-reported outcomes. And so I think in a couple ways, patient-reported outcomes are critical to understanding what happens to our patients. And I think it really does add a new dimension to what we're looking at. And it can be a lens through which we look at our outcomes and make decisions about how we treat patients. These are my disclosures. I'm going to steer clear of any of these conflicts. I wanted to make this statement. I think as it relates to hernia, a complete picture of success is achieved only when we understand long-term clinical and patient-reported outcomes and cost. And so I think it's an important statement. I think that PROs really play a significant part of how we can begin to understand outcomes for patients. I think that complications do not mean failure. And so this is actually a very complex patient who had some significant postoperative issues. But I think in the end, and we measured his quality of life, it's not displayed here, he had a terrific outcome. And so if we're not capturing those things, we're not going to truly understand the impact of the work that we do and how we take care of patients. So for me, we really have a diverse discipline, a wide range of surgical approaches in very heterogeneous populations. And so I think binary outcomes are insufficient. So, zeros and ones for clinical outcomes just don't make sense. Look at the folks up on this slide from large diastasis to fistula, infected mesh, flank hernias. You can't just define something based upon a clinical outcome. Really holistically measuring the impact at the patient level becomes so important. And I think we should reflect on why we fix hernias, to prevent morbidity, certainly, but to improve function and quality of life, and to some degree, appearance. And that's what a lot of our research on quality of life has really shown us, is that how clothes fit, how people look and they feel is very, very important. I think one thing to make note is no 2 defects are alike, and I got 2 snowflakes there. And so you can see just how vastly different these hernias are. And so having an instrument that has the ability to differentiate health states across meaningful domains for patients is so important. Here's kind of my wall of shame. Too many Philly cheesesteaks in my patients, I guess. And so let's kind of define this, though. I had the privilege of being at this conference in 2015 in DC, and that was really what inspired me to want to do research on patient-reported outcomes. Actually, a plastic surgery who was previously at MSK, Andrea Pusick, really was my inspiration, and so I owe a debt of gratitude to her. A PRO is any report of the status of a patient's health condition that comes directly from the patient, without interpretation of the response by a clinician or anyone else. And so I think PROs are so fantastic because, when you measure them, you can really understand what matters to the patient. This patient is a breast cancer survivor, 4-time recurrent suprapubic M5 defect with an open wound. And her goal, really simply, what she told me, she just wants to wear a pair of jeans. And so I think it's wonderful and really great to have alignment between patient-defined outcomes and clinical outcomes. And we'll kind of talk through that. Again, I mentioned this. I think a good PRO instrument is like a prism. You can take the clinical outcome and see so many other things when you use it in clinical care. And I think, again, binary outcomes are not going to give us the total picture. So PROMs are how we measure patient-reported outcomes. So a PROM is a patient-reported outcome measure. It quantifies self-reported patient perceptions of their health and quality of life. Ideally for hernia diseases, we want something that is disease-specific, patient-informed, so the patient's voice should live inside of the instrument. It should be psychometrically validated. And I think it will help us better understand the real effect and the value of the care that we're giving to our patients. I would be remiss if I didn't mention this article by Jorgensen. It's probably my favorite article in the published literature. I love this article so much because what it does, it's a reminder to me of the benefit that we're conferring to our patients with an effective repair. Quantifiable improvement in trunk flexion and extension before and after surgery, but this correlated beautifully with physical health-related quality of life. And so we're doing more than fixing a hernia. We have to measure if we want to understand. And certainly, if you guys reflect on this quote, if you can't measure it, you can't improve it. Certainly, the quality of the care that we're delivering can be measured with quality of life tools, and it becomes an important element of the value proposition. And so I think this is probably my most important slide for a number of reasons. And so I think for me, I'm trying to get to that green circle. I want alignment, good clinical outcomes, and good patient outcomes. We really don't want to be doing surgery with high morbidity and no improvement or impact on the patient. And so I think by measuring, we're going to be able to understand this better. And so there's certainly some scenarios where we could kind of envision the green is the best, and we want to avoid perhaps the scenario below where we have poor clinical outcomes, high cost, and potential no impact or benefit at the patient level. And so this is the way that I believe PROs can help us make better decisions about who we treat surgically. And certainly I'm going to glance over this real quick, but very useful to individualize care, to help track recovery, to foster engagement with patients. We've had a number of focus groups, and to facilitate communication. Just a quick word about generic versus specific tools. So a generic instrument really holistically looks at the patient. So the SF-36, disease-specific instruments are really tailored to the population of interest. Very important to note that. There's a great systematic review for those that are interested in this by Parag Bano and his colleagues at Georgetown, identifying that we have a need in the field of hernia. The Carolina Comfort Scale, and Todd's here, this is such a major contribution to the field, the most widely studied, widely used, prospectively validated tool. It's a very mesh-centric instrument, but a wonderful instrument, and a great paper that I think really proves that disease-specific measure is far superior than generic instruments in understanding outcomes for our hernia patients. We heard about the Hercules, wonderful tool developed by the Cleveland Group. It's a surgeon-informed instrument. It's a very lean instrument. You can see the questions there. I really love this instrument. It helped inform how we develop ours. I'm just going to skip past this, but an example in my mind in the literature that really highlights how beneficial measuring quality of life can be: RCT, laparoscopic bridging versus fascia closure. You wouldn't know that closing the fascia mattered unless you measured quality of life, because there was no difference in clinical outcomes. So a helpful reminder that measuring matters. A great article. And if you look at the data from Mike's group, the Rosen group, improved pain and quality of life even if you had a recurrence. And so you'd think those recurrences are all failures, but there's positive impact on the patients despite the complications. So it becomes imperative that we think about this. A quick word about the instrument that we developed. A lot of qualitative research went into to doing this. So fun working with qualitative research scientists. You can actually see an actual photograph from one of our focus groups with patients, with patient caregivers. We learned a great deal, developed our instrument. It's published in the Annals of Surgery. It's an open access instrument called the Abdominal Hernia Q, a pre and post-operative instrument. So there's a physical component, and I did mention appearance. Appearance matters a great deal to patients. So you can read this. I'm not saying that we do aesthetic surgery on people, but it's important to acknowledge that the symmetry or evenness of the abdomen matters. How they feel in clothing really actually does matter quite a bit. And then the post-operative instrument has surgical team measurement too. How good of a job did the surgical team do in taking care of the patient? And just going back to this breast cancer survivor, you can look at in a visually interesting way her quality of life in the upper right. This is called a radar plot, and if you think about this, the red shape is her preoperative quality of life. Smaller scores are worse, bigger scores are better. And for me, this is a wonderful visual way to represent and quantify the multidimensional impact that an operation had for this patient. And so a really cool way of thinking about this, and a huge impact in terms of some of the dimensions related to clothing and symmetry for this young lady. This is actually just an example from an article that's going to be coming out in Hernia, just looking at a cohort of patients and measuring long-term quality of life. We see benefit over time, even at 5 years. The data lives inside of Epic. I'm just going to kind of glance over some of this. This is the paper that we wrote. But the cool thing is we have the instrument was sensitive to adverse clinical outcomes. And if you look, it was the only instrument between the generic ones and the Hercules that was able to detect and differentiate the risk of complications. So with that, I'm going to give back a minute and 30 seconds. I was so scared. I didn't want to go over. I didn't want to get in trouble, even though I'm the moderator. Measuring to make better, guys. I really mean this. Like, let's measure. Let's do it. Let's measure. Abdominal wall outcomes, they are not binary. They're multidimensional and have to be measured as such. PROs, in my opinion, can help align clinical and patient outcomes and create a common direction for us with our patients. And I think at the end, we all want to learn, do better, and add value. And so I think it really begins by understanding and measuring. Thank you guys so much. It's my pleasure now to introduce Professor Martin Simons, who comes from Amsterdam. Thank you so much, Professor, for being here. Previous president of the EHS, needs no introduction. An absolute privilege to have you here. I had the privilege of actually joining him in Amsterdam a number of years ago, and he was such a gracious host, and we really had a great time. Thank you so much.
Thanks very much to John and Dina, and happy to be here. And when I get invited to do a talk on guidelines, the 10 minutes, which I thought were going to be 12, are never enough. But we'll just go through a lot of information, and I hope I'm not speaking too fast. No real disclosures. Guidelines have been produced by the European Hernia Society since 2009, and we have covered all topics. You can find them on the website. And actually, we've been doing this together with a lot of American Hernia Society people. So thanks for that, and let's keep up the collaboration. John was one of them. An important question is, are these guidelines valuable? We write them for general practice and for all surgeons out there. So a lot of these statements for you as experts are probably very obvious and logical. But some have pretty high recommendation and are strong, and I'm always, wondering, are they being followed? So, for example, a mesh prophylaxis in primary stoma, small bites, small steps, laparoscopic techniques for all females, a simple flat mesh for umbilical, and then not really using gadgets. Are older patients being offered watchful waiting? Is regional anesthesia being avoided in inguinal hernia repair? So I do have one poll. Maybe we could do that one up there now. So I'm going to ask you, there's already answers, that's interesting, but have you read the ventral guidelines of the British Journal of Surgery? And the answers are, well, you see them, yes, and I follow the recommendations, no, yes, but I don't agree with the recommendations, and no, but I will look them up. Well, I'm very happy that almost a third is going to look them up, and some of them are following them. But not all guidelines are read, and not all of them are being followed. We go with the next, back to the presentation, please. So what barriers are there that these guidelines are not being used? Well, there's a lack of awareness, familiarity, agreement. Maybe you don't have the skills. There's learning cultures, differences, the motivation. Some don't have the resources. But there's also a lot of cultural diversity. It's the way we do things is sometimes better than following guidelines, and also medical, legal, financial issues. Like, in Germany, you don't get paid for an inguinal hernia if you don't admit the patient, which is very strange. It doesn't follow guidelines, but it's a financial barrier. What do we have on ventral hernia? Because that was my topic. Well, we have the ventral hernia guidelines, rectal, primary ventral rare cases, incisional hernia. I'm going to talk about that. And the closure guidelines and peristomal. So it does cover quite a lot of topics. But I'm going to show you just in a quick scan that they have a lot of recommendations, but very few of them are strong. So these are still guides that help the surgeons to make their own practice successful. The guidelines for ventral hernia only have 3 strong recommendations. The rare occasions, which is about Spigelian and about cirrhosis and about pregnant women, only 2 strong, and they're on the classification and not really on the type of technique or the strategy. There are 9 recommendations in the rectal diastasis, which really all the evidence is so low that it's almost impossible to write a guideline. And here the strong ones are also on classification and not really on treatment strategies. But there is a brand new guideline on midline hernia, and they have been published just 2 days ago. Neil Smart already showed this slide yesterday. So they're brand new, and I would like to invite you to go to them. They are free access, so you can go there online. And I'm going to scan just through a few of these key questions and recommendations, and I'll stop when the clock stops. They're about the simple incisional hernia guidelines, so 10 centimeters or less, not on complex. I'd like to thank this huge, fantastic crew, and we did it completely state-of-the-art as much as possible. There's always room for improvement, but we did have some patients' participation, and we really looked into the conflicts of interest, disclosures, and we used grade, etc. These are the key recommendations that I will give you, and after that we can maybe go into a little bit more detail, but if you have this slide, we can get to the most important points. So patients with an incisional hernia should undergo cross-sectional imaging prior to surgery using CT or MRI. Patients with symptoms that adversely affect their quality of life and are medically fit should undergo surgery. So there's a lot of room for watchful waiting, and quality of life is what we're aiming for. All patients should be pre-optimized, which a lot of talks on those in the presentations. And for the majority of patients, a mesh repair with fascial closure and the mesh in the retrorectus plane is recommended. Now, the best mortality, as you all know, and we've had talks on those, CT, you need it for diagnosis, but also for preoperative planning and your surgical technique to follow. What is a complex hernia? And the question is, when will fascial closure be possible? Well, we found in the literature that there are different ways of finding out if it will be possible to close, and those are the ones that are mentioned to use. Do all incisional hernias need a surgical treatment, and what are the important outcome measures? Well, the risk of an acute accident is only 1 to maybe 2.5% by 5 years, and that's a lot lower than the complications we offer patients with certain surgery we do. And the most important outcome that we have a good practice statement on is the quality of life and not recurrence, etc. But John had a very nice presentation on the importance of doing this by asking the patient. So actually what the guidelines also ask you to do is to have a shared decision, have the patient in front of you and just balance the pros and cons, and then talk about a possible strategy. The pros, the cosmesis, pain improvement, abdominal wall function, the risk of strangulation that might go away. But the cons is a huge list also, and we really advise tailor and talk with the patient about the options that you can offer them. So the modifiable risk factors are all pretty well known: BMI, poorly controlled diabetes, and smoking. Tackle those. The difference in mesh versus suture repair is an interesting one, because truly there is very, very low evidence on the fact that we are using mesh in every patient, but we have a upgraded recommendation. So it's a strong recommendation on a very, very low certainty of evidence. And you can see that in the manner we did this, with Cochrane help, that the forest plots here for mesh versus suture are in favor of mesh, but very few studies. Old studies. So what are the different positions? I think this is an important question that surgeons will always want to ask. Where do I put the mesh and what technique do I use? What we advise is that you use the retrorectus plane, but you have to be familiar with all planes, because all kinds of patients will require a different approach according to their specifics of the hernia. But we do advise that the intraperitoneal mesh should be used with caution. Very low evidence again, but it is something that when we panel all these recommendations that we get from the literature, we try to find a consensus with about 20 experts, and there is a warning: be careful with the mesh in the abdomen. So, of course, know your anatomy, and let's all use the same classification system for where we put the mesh. Then the onlay, still quite popular and doesn't have bad results in the literature, but you do see here on the forest plots that retrorectus is preferred with just a very few studies, and they're heterogenic and they're full of bias. But we have said, please go for retrorectus. And a very important question is, should you go for open, laparoscopic, or robotic? Well, actually, none of them is superior to the other. And it just depends, as we say here, on the patient and hernia characteristics provided by the surgeon using a correct technique. So the bridging, we think that the facial defect should be closed. Strong recommendation, very low certainty of evidence. This is the forest plot, so you can see that it's not in literature superior bridging versus facial closure, but again, only 3 studies with pretty, a good bias score. The seroma and the hematoma difference is also in favor of facial closure, but not statistically significant. So I'll skip this one. They asked me also what are the future plans. The guidelines that we wrote sometimes took 2-3 years, a lot of effort, huge amounts of work, and we want to change that a little bit more to guidelines that are absolutely state-of-the-art, produced by trained teams, which involve methodologists like Cochrane, biostatisticians, epidemiologists. You have to use agree, of course, but we're going to have much more input of patients in writing these guidelines, and we really have to solve the conflicts of interest that there are from surgeons using certain techniques and writing their own guidelines, and of course industry. And we want to start focusing on just on the key questions that are important. So it'll be a very, very aggressive, dynamic way of quickly coming with a key question and an answer to just that key question, and not waiting 3 years for the new guidelines. So continuous work with fast announcements on social media, which you see here also. And just as takeaways, guidelines have benefits for surgeons and patients, that's for sure. Critical reading, though, is warranted. They are guides, they are not protocols. I've talked about the methodology, and I'd really like to work together with the American Hernia Society in the future and write more of these guidelines. So thank you very much for taking your time to listen to me.
Terrific talk, and the amount of work that goes into these guidelines is just so impressive. I'd like to now call Dr. Jonah Stolberg, who's a professor of surgery. He's the vice chair of research at McGovern Medical School at UT. Absolutely a sensational surgeon and speaker. Looking forward to his talk on mobile data capture for outcomes. Thank you, Jonah.
Great. Thank you, John, and thank you to the conference committee for the privilege of the podium. I know I'm the only thing standing between you and food that's coming, and I'm sure that in addition to being last, I'm probably least on this panel. So I'm going to quickly wake everybody up with a question, all right? How many of you have a cell phone? Let's raise your hand. All right. How many of you have a smartphone that you've been using most of the session, right? Okay, we almost all do. Now, how many of you printed out your airplane ticket so that you would have a printed airline ticket? Okay, so we have 1 or 2. All right. How many of you use your mobile device for your airline ticket and all of your travel? Okay. Now, for all of those who've had to undergo healthcare for themselves, whether it's a surgery or whatever, how many of you have two-way communication devices with your surgeon team, medical team? How many of you use that in your own clinics? We have some? All right, we're getting better. So I've been asking questions like that for the last 5 years or so, or 6 years, and it is slowly ticking up. So slowly, I think we are getting some infiltration of mobile data capture in real time. I do have one disclosure, and it has nothing to do with this. According to the Pew Research team, you are not alone. Everyone else in the United States also has a cell phone, okay? 97% of people as of 2021, and then 2022 data should come out soon. And smartphones are also overwhelmingly the rage. We know this, right? Even our patients with little to no healthcare don't have it. And our healthcare systems know this. So they've started to do things. Now, these are all the places I get my care. So this is how my different healthcare teams communicate with me. They either text me, they tell me to go to my app, right, that connects to my EMR, or I sign into this, all right? But what I'm talking about is that my clinical practice, in my opinion, my clinical practice is much more dynamic. And around the time of surgery, I want to continually interact with the person in real time so that they have an understanding of what I want to do and they get bite-sized information in the time that I want it. So what does that look like in practice? That means about 3 weeks before surgery, let's say it's a routine case and I see them and it's about 21 days before surgery, I see that patient in clinic. So I now have a mobile device that automatically enrolls based on the case request, okay? The patient is invited via text to download the app or continue to communicate via the text. They can also use a website. I confirm specifics with them. So a lot of times patients come in and then they go, oh yeah, that's right, I forgot I also take a multivitamin at home, or I also take St. John's wort, or I take a baby aspirin, or whatever, and they can update and confirm the information that they gave us. And then they can say okay to preoperative reminders, just like you kind of have to do for everything else. Is it okay if text messages, data applies? Okay, then they're usually seen in a preoperative clinic, let's say anesthesia or something like that. They get a reminder about that just on their app or via text. Those tasks are then confirmed, information is edited. There's all sorts of things that can go into that, right? So if a patient's elderly and they need a frailty screen, it'll alert the anesthesiologist and the patient that this is what they're going to be doing. If there are questionnaires that they need to answer, all of that can be done as tasks preoperatively. Then you have your OR day. Then you have updates and not modifications if necessary. Let's say you started at minimally invasive and it went to open. You can just change that, okay? So your OR case can change. But then what happens on post-op day 1? So post-op day 1, they get personalized asynchronous communication, all right? Now, this is not the future. This is easy to do now, all right? I first built something to do this in 2016. I did it through MyChart and was trying to use Epic, and I hated it. That didn't work. Patients didn't sign up for it. Our enrollment rate through MyChart was something like 30%. So now I started using one of the products from one of the companies. I've blurred it out on this because quite frankly, I don't speak for them and that I don't think that's relevant. What I think is relevant is the details of how we communicate, the interface that we use, and the fact that we can capture this kind of data in a new way. So things like this will happen. This was an inguinal hernia patient, so it was a targeted question about whether or not they were still able to urinate. I think we need to move beyond this concept of, missing presumed well. This is what the patient interface looks like. They have lots of products for other things, so I'm just showing the arthroscopy so that people don't point out and go, oh, I would do this inguinal hernia question thing differently, all right? But it has all sorts of features that are built in, like longitudinal care guidance, daily push notifications, secure messaging. One thing that I'd like to get across is in a lot of ways, this is fundamentally different. What I'm talking about here is fundamentally different than having a MyChart account that you need to log into, or that I get a text that says, oh, please log in. There's a message from your provider and it's like, hey, you're gonna owe $5 in 2 weeks when you show up for your appointment, right? This is stuff that I decide and the pathway is all designed by me, and so it's modifiable. And as I said, there are a bunch of groups that do this now. This is what my provider interface looks like. One of the things I like about this is that I could have 30 patients out there, but I really want to focus on the ones that I'm worried about or that are having problems. Let's say they had a fever. Let's say they had, some other complaint. Those then get flagged as red. Okay, things that are flagged as red, my office is alerted to. The nurse can call them back right away. I can even set it up to page me if I want. So we should be thinking about how that type of interaction with our patients outside of the immediate surgical episode can change our practice. What happened to me was this is the first year of using this, which was like 2017, I think. And in that first year, all of a sudden I had 89% response rate across a year. And I was like, holy cow, that's fundamentally different than all the research I'm doing, right? My survey research gets like 30% feedback if I'm lucky. And that's with begging and borrowing and stealing. And then I was able to quickly just plot things like average pain reported after by patients. And I do a lot of pain research and I study opioids and use and stuff like that. And I said, we need to integrate that, okay? And so if I can get 86% response rate at 1 year, I gotta do better. But then we started to look at, well, what does that mean about aligning not only our clinical care, but our research and our quality improvement aspects into this sort of digital platform? And how can we use this to align across all of these different organizations that have different definitions, different ways of looking at the data? Now we can get data directly from patients, like we just heard, like PROs. So this is a study that's now closed, a collaboration that I want to just touch on briefly. The objective was to test the feasibility of leveraging mobile technology to rapidly disseminate opioid-related education material and patient-generated data collection to improve quality and standards of care. So with the Patient Education Committee, we took the approved guidelines for patient education, we literally fed them into an already existing platform, and then we wanted to learn from that. What we found was that patients were able to be enrolled automatically. All surgeons had to do was opt out if they didn't want us to do this, okay? Surveys and SMS triggers from the smartphone were all done automatically for this. We had baseline preoperative surveys about chronic opioid use, promise, and then we designed postoperative surveys that were an add-on to the clinical care, just to look at how people were doing. This is all now closed, but there were about 9,000 patients over about a year and a half of implementing it. And you can see here, this is what's fundamentally different, all right? The baseline survey response was 84%, and after their surgery, the postoperative survey response rate was 97%. So when you have a good clinical interface, when you give real-time information and you utilize the thing that's already in everybody's hands, it's easy for them to do. These are bite-sized things that they do quickly. So now I'm going to quickly touch on what we're doing in the future to try and expand this research work and also integrate it into other levels of care. I now I work part-time at a county hospital, and they have very low resources, okay? And so what we're doing is we're developing an app that we named the Equity app because you have to have a cool slogan or whatever for to get funding for these things now. But it's essentially a trial of whether using text-based, low literacy information in real time improves quality of care for patients at a county hospital, okay? So they don't need a smartphone, they don't need videos that come down, it's literally just a text to them. And it says things like, hey, stop your aspirin because you're having surgery in 7 days, okay? Or did you complete your bowel prep? Because the two groups we're using are colorectal patients and laparoscopic cholecystectomy patients, okay? So then they get their standard of care, everybody gets their standard of care, but they get the adjunct of real-time reminders and then the post-op adjuncts of information, data collection about how they're doing. So this is what a care flow diagram looks like for this, okay? The surgical consultation, baseline PROs, patient education and engagement, all via the app. This is without extra resources used by, as I said, a low resource county hospital. They get a pre-op call that they always get to let them know that they're having surgery, and then all these post-operative data. And so my message here is that we need to start thinking about ways that we're integrating the mobile piece of this technology. Everybody already has the electronic medical record, okay, into this care loop with patients where you have the EMR, you have the surgeon, you have the patient, and you have the mobile communication platform that allows us to extend our care of these patients to the preoperative and the postoperative setting. And with that, I think it's as quickly as I could go through that. Thank you all for your attention, and I'll conclude.
That was really impressive, that 89, 96% response rate. It's really great work. If there aren't any questions, I can at least start off with a couple that I had. Jonah, what's the infrastructure necessary to implement something like this? Do you need a nurse practitioner or research, dedicated research fellow, et cetera?
No.
Yeah.
All right, I'll use his. So all I would say is that there are different products out there. There are different ways of doing this. The most important thing is to set it up correctly, but it can be done very easily with time up front. My recommendations, if you're just getting started, are to pick sort of one procedure and one group and build a care pathway. Okay, so the easiest way to do this is to say, all right, I want to do this for my inguinal hernia patients. I want to make sure that they are peeing after surgery. I want to check on surgical site infection. I want to follow them with PROs. And then build something that is easy to do around that. I would pick one or any of the companies to assist you with that. Building it myself, I found the hardest part is the constant updates. There are ones that connect directly to your EMR. So for us, it's really low maintenance because the EMR automatically pings, like when you put a case request to enroll the patient, the phone. But there's a whole spectrum of how to do this. You can have it connected to the EMR or not connected to the EMR. I think the key is to keep it simple, directed, and then grow from that.
All right, we have some questions at the podium. What a dynamic duo that I may or may not have been with late last night. Go ahead, Professor Smart.
John, great talk. Thank you very much. But one of the problems with patient-reported outcome measures is that many of the ones that are out there are not formulated correctly according to the COSMIN guidelines, and in particular, the degree of patient engagement. You very nicely showed the photos of you doing those sessions, but how do we get to the stage where we use patient-reported outcome measures that actually measure what they purport to measure, rather than ones that measure things that surgeons think that this patient should be doing? Because there's a lot of problems with some of the ones that you showed. They have not been developed correctly, and there are significant methodological problems with them.
Yeah, such an important comment, and not to pick on any of the instruments, because I feel personally like each one has contributed to our understanding of how to make a good instrument in AWR. But I think that the Hercules, for example, lacks content validity, specifically meaning that like a group of surgeons came up with the questions. They probably weren't wrong, but I think fundamentally, from a qualitative research standpoint, you can't do that. So you have to ask the patients, do the focus groups, generate the items, and then make the instruments. It's such an important concept. It takes a lot of work, and there's scientists that do that. And so it's a great, insightful comment, and we like to think that the instrument allows the patient, the patient voice to be heard, which is important.
Yeah, so a couple of comments like the SRC for hernia centers. The SRC, if you want to become a hernia center, essentially you can get an emergency and urgent approval for a surgical center of excellence by showing you've done 100 cases, paid $2,900, and in 2 weeks they'll send you a certificate saying you're a hernia center of excellence with nothing else. So that means nothing. And so I don't even know, I mean, I talk about it because it's comical, actually. Yeah. And so just to be clear about that. And so, but for John, what you're doing now with, like, you actually have this in your EMR, you're making it available. Patient response, we talked about it yesterday, like for the AHSQC, patients know they're going to get these, they still don't respond, where they get 6 to 9% responses when they're programmed. With what you're doing, what is your patient response, and how do we get it?
Yeah, that's an important question. I mean, we used to do this by handing the patient the printed instrument, and then we had it on iPads, and it was really working great in my clinic, but it didn't generalize, and it wasn't being done across the Penn system. We made a big pivot, as you pointed out. I didn't show the slide, but we went to an automated, time-based, the PRO goes to the patient through the portal based upon if they get scheduled for surgery. And so I don't have the exact number. All I know is it's not as high as I want it to be. And that's an issue. I think, patients get so much information before surgery and so many pings. I think even with 3 reminders, they're just not filling it out as high of a rate as we want. And so I think there's an opportunity for research there to get better, but it's a great point. So it's a trade-off, right? If we're getting it to everyone, but the rate is lower, it's a trade-off.
So but when can it be available, like with Epic, it's going to be available nationally for us to be able to download onto our system? Yeah,
I think it's a good question. I got to talk with the folks. I think it's a custom bill, but I mean, hearing some of the stuff, from Joan, I mean, there's opportunities to make this easier for all of us to use PROs in the real world. And so that should be a goal of ours, I think, as a collective society and of the AHS, is to make it easier for surgeons and patients to use PROs in practice.
I think we are underutilizing the electronic medical record, specifically Epic, which is in something like 79% of all hospitals, et cetera. And I'm sure that number will be closer to 100 soon, of data collection and things that we can standardize, which has always been really difficult. And it's going to be difficult because all the hospitals will have to approve it, et cetera. But I kind of see that that's where we're going. All right, well, I don't want to keep anybody from lunch. Thank you to all of our talkers today. This was fantastic. Thank you for everybody in the audience, and having a good rest of the day.
Thanks, everybody.